Good
Good
evening,
evening, friends.
yeah.
Good evening, friends. It's been a pleasure to convene this very important academic event of IAGES Prime Time. Prime Time showcases the best of the talents in country and out of country. It happens on a monthly and fortnightly basis. We have the most eminent speakers invited by the president of the IAGES to deliberate and share their lifelong wisdom, which is many times path-breaking and many times life-changing and very stimulative for the young surgeons. Ladies and gentlemen, I have the honor of inviting the president of the IAGS, Dr. L.P. Thangavelu, sir, the most dynamic president IAGS has ever got. IAGS has lined up multiple activities, and president has been traveling almost every week to different part of the country, hosting the basic programs, advanced programs, endoscopic fellowships on every day, and he's going to represent IAGS to the Malaysian Surgical Society shortly. I have the pride and privilege to invite the president of the IAGS, Dr. L.P. Thangavelu, to welcome the faculty and the guests online and on various platforms. Over to you, President.
Good evening, friends. Good evening, ladies and gentlemen. I'm sorry that there is some delay because I'm in Ahmedabad attending a false program of IAGS, and I'm very happy and honored to be in this program today, and in which there are two eminent great speakers, great scholars are going to speak for us today. And Rakesh Kalapala and Amit Maydeo. I do not know them personally, but I am ardent fan of these two people. They are great people in their own capacity. And my good friend Randeep Wadhawan is chairing the session. And Amit, my son Ashwin Thangavelu has told a lot about you. Personally, I have not met you, but I think we will be meeting in our annual National Congress at Coimbatore, February 9, 10, 11, 23.
Okay.
This is my welcome invitation. Invitation to you, and you're most welcome, and you are my guest there. Okay, thank you, Amit. I know about you all, and I need not waste my time in elaborating all those details here. Similarly, Nageswar Reddy is my friend, and AAG is known all over the world. And Rakesh Kalapala is a great surgeon and is doing a lot of work in bariatric surgery area. And my secretary is there, Sati Smita. I welcome Kanavel. I'm sorry for the delay. And always, because of some sort of this thing, all these things happening. And I welcome you all for this program, and I welcome all the participants for this program. My dear friends, IAGS is a primary association for minimal access surgery in India, and in which there are about close to 10,000 people are life members in IAGS. 10,000. That means it's the largest association in the whole world for minimal access surgery. And I'm really proud to be a president of this year. And we are conducting so many academic activities and programs. We have, to be precise, I don't want to take too much time on this, but at the same time, I want to tell certain things that briefly to tell that these things, will give you an idea about IAGES. We are involving for the past 2.5 years. You all know that during COVID time, we have been conducting online programs. And in online programs, our prestigious program is Prime Time program, in which we are having two eminent speakers today with us to give a lot of ideas about bariatric surgery and how to manage the complications in endoscopy, all those things. IAGES, you all know, is involved in a lot of research activities. And we are coming out with JMAS, Journal of Minimal Access Surgery, once in 3 months. And we are encouraging young surgeons to actively participate in research activities. That those who are publishing best research papers for 5 persons, we are giving annually 1 lakh each. That means 5 lakhs to encourage research activities. The best papers published in JAMAS, it's an index journal, you all know, well-recognized journal. For that, we are selecting again 5 persons, and we are giving 1 lakh each for 5 persons. Best paper selected by our committee in JMAS, and we are encouraging the youngsters are the future of our association. They have to lead the association in future. We want to encourage the youngsters, and we are giving traveling fellowships to 10 young surgeons across India. They can go to any recognized center and work under a recognized surgeon for 6 weeks. They will be given about 1 lakh each for each person. That means we are giving 10 lakhs. We have allotted 10 lakhs fund for this traveling fellowship alone. Best postgraduate thesis. For 3 theses we select every year. 3 or 5, I'm sorry, 5. And we give about 1 lakh each for 5 lakhs. And in our annual National Congress, every year we are having our annual National Congress. The coming year in February 9, 10, 11, we are going to have our annual National Congress of IAGES. Going to be a grand gala event at Codicia Trade Fair Center, Coimbatore. And Coimbatore is known for laparoscopy, surgery, and endoscopy. In all, it is reputed. I need not say about all those things. It's known for its hospitality, everything. And in that Congress, we are encouraging postgraduates in surgery, and we are giving best video presentations. We select 3 best video presentations and give 1 lakh each for 3 best presentations. Similarly, we select 3 papers presented. We encourage the PGs to present papers in our National Congress, and we have a committee, and if they have selected best 3 papers will get 1 lakh each. And so we are having international collaboration with so many international associations, and regularly conducting our online programs. Thanks to Kanagavel, we are having association with ALS, Association of Laparoscopic Surgery of Great Britain and Ireland, and SAARC countries, and SAGES, IPSIS, all the leading associations. We are having collaboration, and we are associating ourselves with research activities as well as international exchange programs and international, online programs. And we invite them for our conferences. They are inviting us for their conferences. For example, ALSDB, we are going to participate in October in Newcastle, England. Like this, IAGS, I can go on talk about the activities of IAGS for the entire period, because want of time, I stop with this here. And as everybody, I'm also very keen in listening to these two giants of endoscopy surgeons in our country. And I'm really proud of you, Amit and Rakesh, for your, and I'm very grateful to you on behalf of IAGS for accepting our invitation and participating in this program. Thank you.
Thank you, President. Thank you for this sharing of thoughts on various research and promotional activities of various academic initiatives of IAGS. We look forward for more intensive academics with your leadership, sir. Ladies and gentlemen, now I have the honor of welcoming Dr. Randeep Wadhawan. Dr. Randeep Wadhawan is the most eminent laparoscopic surgeon, and he doubles up as the FALS convener and the executive committee member of the IAGS. He is one of the best outgoing students from the Rohtak Postgraduate Institute of Medical Sciences, both undergrad and postgraduate, and has been instrumental on setting up various, the earlier institution where he worked. He created the National Board and present institution also. And he is also the examiner of the National Board of Examination. And his early training involved spending few years at Sir Gangaram Hospital, the mecca of laparoscopy and this era. And he has been very long time associated with the IAGS. He has FAGS to his cap, and he has been trained at multiple centers in the United States. And later, right now, he heads the minimally invasive laparoscopic and bariatric surgery program at the Fortis. Ladies and gentlemen, I am also to inform he is the president-elect of the Obesity Surgery Society of India. So may I have the honor of inviting Dr. Randeep to moderate today's program. Over to you, Dr. Randeep.
Thank you, Dr. Kanagvel, for that a long introduction. Thank you very much. And at the outset, I'd like to thank the leadership, our president of IAGS, Dr. L.P. Thangavelu, for organizing the IAGS Prime Time and continuing with this IAGS Prime Time since last couple of years. Dr. Kanagvel, the convener of the IAGS Prime Time, congratulations to you for organizing one better than the other, almost on a monthly basis. I have immense pleasure in welcoming Dr. Amit Maydeo. Now we know that there is a definite role of endoscopy in bariatric, in obesity and the treatment of obesity. We know there are specific indications wherein endoscopy comes in. We are bariatric surgeons, but we do understand that in patients with lower BMIs, patients with higher BMIs where a bariatric surgery may not be done right away, endoscopy comes in. Sometimes the patient chooses to get a bariatric endoscopy for weight loss. So there are multiple indications, and no better than Dr. Amit Maydeo, who's known both nationally and internationally and doing a huge volume of bariatric endoscopy to tell us more about it. Immense pleasure in welcoming you. He comes from the city of Mumbai. Over to you, Dr. Amit, for your talk.
Thank you so much, Dr. Wadhawan. And it's a great honor and privilege for me to talk to you today on this topic of procedures, endoscopic procedures for obesity and probably for type 2 diabetes in this IAGES prime time. And my special thanks to the president and the entire organizing committee of IAGES. You're doing a wonderful job. So I'll just start sharing my slides now.
We are able to see your slides, sir.
Can see?
Yes, sir. Okay. Good to go, sir.
Okay, thank you. Okay, so to begin with, I just want to say that this is a very recent article I came across, 2020. I think there are not too many epidemiological studies published and made in our country, but this is a study prevalence of obesity in India, a nationwide cross-sectional study, and I was myself amazed to note that the overall prevalence of obesity in a country like India is 40%. In United States, it's supposed to be 65%. But in India also, this obesity issue has been rising, especially over the last few decades. And what is interesting to note is this obesity, as it is seen in Asians and especially Indians, is a little bit different from the obesity we see in the Western population. For example, you see here, this is the new proposed classification of BMI in Asians as well as in Indians, where they have shown that even at a low BMI, anywhere between 23 to 25, these people are at increased risk of comorbidities, and 25 to 30 moderate risk, and even above 30 it can be severe risk. So even though this is so-called class 1 class 2 obesity, now what is the main reason? The main reason is in Indians and in Asians, obesity is predominantly central obesity, or what we call as visceral obesity, where fat collects predominantly in the abdomen, in the peritoneum, and also sometimes in the viscera. So these can cause various issues. And that is exactly the reason why various types of treatment modalities have evolved. And there is no doubt that surgical procedures have been the mainstay of treating patients who are severely obese, morbid obese. And surgical results also have been very, very good. Surgeons have done a fantastic job. But as you can see from this slide, as the surgical procedures, the effectivity of the procedure becomes better and better, and so is the risk involved in that procedure. And simple lifestyle management, diet, even though can be said very simply, many of the patients don't tolerate it. And you see here various types of surgical procedures. Even today, lap sleeve gastrectomy is the most commonly performed surgical procedure. And in spite of refinement in surgical technique and excellent surgical bariatric surgical centers all over the world and even in our own country, there are some complications associated with these procedures. And it so happens that very, very few patients actually accept surgery. And many bariatric surgeons will agree with me that I think more than the technique of performing the bariatric surgery, what is most difficult is to convince the patient to undergo the bariatric surgery, and maybe to do a proper and excellent follow-up by which we can monitor and keep their weight loss on a long-term basis. Another very interesting fact is that if you were to see this paper published in 2021 in the International Journal of Obesity, and if you were to see the various comorbidities associated with obesity and how much weight loss is required to reverse this comorbidity, you see here approximately anywhere between 5 to 15%, 5 to 15%. So all complications of obesity, whether it is diabetes, BP, dyslipidemia, or type 2 diabetes, or various other things, the average total body weight loss required is only anywhere between 10 to 12%. So therefore, can this be achieved by simpler methods? Yes, possibly. And that is exactly the reason why endoscopic methods to treat obesity have now started flourishing. They have started getting established as a middle of the road approach, especially for those patients who cannot handle a proper lifestyle management, or those who don't want to undergo bariatric surgery, who are getting scared of bariatric surgery. But we have at least some option by which we can offer them a moderate amount of weight loss by which they can prevent the comorbidities from happening. Now, if you see, there are few established procedures in bariatric endoscopy as far as obesity is concerned. And the first one of them is placing gastric balloons, which can be called as gastric space occupying therapy. And various types of balloons have now come into the market. Different types of balloons are there. In fact, I know that we used to place balloons even 45 years back, even before I started doing endoscopic work. When I was working in Hamburg, of course, those balloons were very crude, so they were not tolerated by the patients. But now these various types of balloons are there. You can have air-filled, gas-filled, fluid-filled balloons, refillable balloons, and nowadays even swallowable balloons. And the most accepted indication of balloon placement is the primary therapy of moderate class 1, class 2 obesity, anywhere between BMI of 26 to 39. It can be also used as a preemptive therapy for sleep apnea, hypertension, or it can be used as a bridge therapy before bariatric surgery or a liver transplant. And of course, it can also be used for the reversal of NASH. There have been some patients who have been recently, nowadays, the liver department from our hospital, they have started referring patients of NASH for the treatment of this by placing a balloon. And if you achieve a 10-15% total body weight loss, they found that their medications work better. And these patients, the NASH reversed. Of course, there are a few absolute contraindications. The stomach should be good. There should not be portal hypertension with portal hypertensive gastropathy or varices, acute duodenal ulcer, severe gastritis, coagulation disorders, and of course, pregnancy and a large hiatus hernia. And if you were to see which balloons are available in India, you can see here these three type of balloons are available. One is the Orbera, which is being marketed by the Apollo Endosurgery, and then we have the SPATS 3 balloon. This is this one, the Orbera balloon, where this balloon is filled up to around 500 cc's with fluid, and then it can be left inside for approximately 5 or 6 months. Then it has to be taken out. And usually with this, we can achieve a reasonably good weight loss. This cannot be readjusted. But the advantage of the SPATS 3 balloon is that it has got this external attachment, and this also goes in the stomach. But this is a refillable balloon. So if the patient cannot tolerate, we can start initially with a 300 cc, and then after a few days, maybe a few weeks, call the patient back, increase to 500, and then it can be inflated up to 800 cc, and then you can leave the balloon almost up to 1 year. So this has shown extremely good results. But the most recent advancement, most recent introduction in India is this Allurion swallowable balloon. You see here, this is only in the form of a capsule. You don't even need an endoscopy. The patient is just given this balloon capsule to swallow. Then through this catheter, you can fill the fluid and just pull the catheter. The balloon remains in the stomach. And after 3 months or 4 months, this balloon automatically disintegrates and passes out through the stools, through the gut. So this is a thing which is very easily accepted by patients. But if you will see the overall approximate total body weight loss by all these three balloons is anywhere between 10 to 12%. One of the most interesting endoscopy procedures, which is now reasonably established in the world and also established in a few centers in our country, and it is used in clinical practice, is a gastric restrictive procedure, which we call as the endoscopic sleeve gastroplasty. Now here, what we actually do is we pass in an endoscope, and inside this stomach, what we do is, initial description was that we mark on the anterior wall of the stomach, on the posterior wall of the stomach by argon plasma coagulation. And then all that we want to do is do a full thickness plication of the entire greater curvature of the stomach, starting just proximal to the incisura angularis and stopping just distal to the fundus of the stomach. So we don't include the fundus in this case. And either you can take such type of sutures, or you can take a U-shaped suture, because this suturing device is attached to the tip of this double channel scope. And this way, we can plicate the entire stomach and make it reduced not only in size, but also in length. And you see here, the most accepted indication again is class 1, class 2 obesity, 26 to 40 BMI, treatment of comorbidities, post-lap sleeve gastrectomy weight regain, where the stomach has again dilated. Absolute contraindication is similar to the balloon, and relative contraindication is severe gastritis or high risk for GA, because this case has to be done under GA, and severe gastritis can cause bleeding as we are doing the suturing. Well, for this, we use a double channel endoscope like this, and this is the suturing device. This is what is attached to the tip of the double channel scope. We usually use an over tube, but nowadays, after experience, we can even avoid the over tube. And this is the needle which has been fit on the tip of this needle driver. There's a needle holder and a needle driver, and the tissue of the stomach is pulled by this screw type of a device, which is also called as a helix. Now, just to show you how this procedure is actually being done, you can see here, this is the endoscopic picture, and this is the animated cartoon. So this is the needle driver at the tip of this endoscope, and this is the needle holder. So the needle is fixed on the needle driver first. You can see here, we are fixing the needle. And then when we open this needle driver takes the needle back on the opposite side. These are the two towers of this suturing device. You can see the tip of the needle over here now. Then we position our endoscope just proximal to the incisura angularis. And then by using this screw type of a device, it is a helix. Now we are going inside and we push it against the wall of the stomach. and by rotation, the screw is gone inside, almost full thickness in the stomach. Then the stomach wall is pulled in between the two towers. And then once it is pulled, we take the needle through and through the tissue on this side. And then the needle is again held by this needle holder and pulled back. And this way, we can achieve one suture. So once one suture is achieved, this way we can keep on taking the continuous suture, starting on the anterior wall, slowly coming all along the greater curvature, and then going along the greater curvature till the posterior wall, and then again taking a U-turn. Just to show you over here in actual case, now here, we are going inside the stomach. Now we start suturing here on the anterior wall, and then we take one suture after the other. You can see here, it is a running stitch. And this way, we can keep on plicating the stomach. And after coming to the posterior wall, we again take a U-turn, leave the needle inside, and then cinch it. And this way, we reduce not only the size of the stomach, but even the length of the stomach. In fact, if you were to see in this representation, left side is the normal stomach, and it appears almost as if you have performed a laparoscopic sleeve gastrectomy. The advantage of endoscopic sleeve gastroplasty is it is not only a gastric restrictive procedure, but it maintains the anatomic structure, maintains the innervation, maintains the blood supply. It is potentially reversible, reproducible, repeatable, absolutely safe. In many published literature, there is no serious adverse events. It is much more durable than the balloon. And very importantly, it can always be upgraded with a surgery. What is the latest data? From one single center, you see 1,000 patients from Saudi Arabia. You see here only very few adverse events. But overall, if you go to see total body weight loss at 6 months, 13.7%, at 18 months was almost 15%. In fact, there has been also a systematic review and meta-analysis on the efficacy of endoscopic sleeve gastroplasty. But what is more important is very recently this published data on comparing endoscopic sleeve gastroplasty versus a lap sleeve gastrectomy. This is a very simple non-inferiority propensity score matched comparative study, only to show whether it is inferior to lap sleeve gastrectomy. You see here the mean difference of weight loss between a ESG and a LSG is only 4.8%. So therefore, it is not inferior to a lap sleeve gastrectomy. In fact, if you were to see the remission of comorbidities, dyslipidemia and hypertension are almost similar between the two techniques. Diabetes, lap sleeve gastrectomy is a little bit better. So therefore, for this moderate obesity patients, this is one of the techniques which should be used. And another similar technique, which is similar to endoscopic sleeve gastroplasty, is the post-2 procedure, which is by using a little different device. Here, the data is not too much, just a single center experience of 73 patients, but almost similar total body weight loss of 15 to 16%. Now, there are some procedures which endoscopists have also now attempting in the experimental stage for the treatment of type 2 diabetes. And that is predominantly to treat the foregut, either to bypass the foregut or to replace the foregut mucosa. So this can be done either by using an endoscopically placed sleeve, duodenojejunal bypass sleeve, or by using a technique by we can do a duodenal mucosal resurfacing and change. Now, what is the whole idea of doing this procedure? It has been said, it has been postulated that in those patients who have got type 2 diabetes, they usually have abnormal enteroendocrine cells in the proximal gut. So therefore, what happens is this causes impaired signaling to the pancreas to secrete insulin, and therefore these patients develop insulin resistance. But if you bypass this, and if the nutrients directly go and are exposed to the distal jejunum or distal gut, it comes in contact with the L cells, and these cells cause secretion of GLP-1 and PYY, and therefore it increases insulin secretion. So one of the techniques is to just bypass the duodenum by passing this duodenojejunal bypass sleeve. A very, very simple technique. It's like placing a stent. So by endoscopically placement, you go inside, and by placing a guide wire, all that you have to do is you go in and place a guide wire right in the second part of the duodenum, almost in the proximal jejunum. And then over this duodenojejunal bypass sleeve is passed, where the funnel of the bypass sleeve remains at the pylorus, and the silicone goes right till the distal jejunum, so that the nutrients from the stomach go directly into the distal jejunum. Thereby, we are causing insulin sensitivity. Initial data you see here, published in 2013, a good improvement in HbA1c and a robust continuous weight loss. However, from this initial paper, they had a few complications which were not acceptable in this trial. So therefore, the trial had to be concluded and this device was taken away from the market. There are some studies going on about the new endobarrier device, which is being done, in fact, by AIG, by Rakesh Kalapala, and that device is still not available in clinical practice. What about replacing or changing the foregut mucosa? This is a very, very unique technique where by using a special instrument, we can actually burn the mucosa beyond the ampulla obvator till the DJ plexure. And then this destroys the abnormal enteroendocrine cells. And within a period of 1 month, new cells will come and new mucosa will come, by which they have found that we can improve the metabolic parameters of this patient. So this is done by hydrothermal ablation of the foregut mucosa. You see here, for this, there is a device which looks almost like a simple catheter like this, which can be passed over a guide wire. And then by inflation, this balloon can be inflated. And in this balloon, we can inflate, we can put water, which is 80 to 90 degrees centigrade, and by which we can ablate the mucosa of the duodenum, starting from the ampulla obvator till the duodenojejunal flexure. By using this technique, the results of the first human study, you can see here, once again, hepatic transaminases, which are improved, metabolic indices, HbA1c are also improved. But let me tell you, these are still experimental. Now they are trying to see how much amount of mucosa needs to be ablated. Longer the mucosa you ablate, better are the results. And finally, endoscopists have also started attempting a procedure which is almost similar to surgery, that is a jejuno-ileal bypass by doing a magnetic anastomosis. In this case, what we can do is we can actually release a hexagonal magnet inside the jejunum, inside the ileum. Now these are magnets. So once you have released these magnets by using enteroscope, what happens is that by doing this, these two magnets naturally come in approximation with each other. And once these magnets come in approximation with each other, it causes a pressure necrosis of the tissue in between. You see here now, this one magnet is released by an enteroscope passed from above in the jejunum. Second magnet is released in the ileum. And these two magnets come in close contact with each other. There is pressure necrosis in between. Within a period of 1 week itself, this mucosa, this whole wall of this anastomosis gets necrosed off, and you perform an endoscopic side-to-side jejuno-ileal bypass. With this, there have been excellent results in the initial studies, but once again, an experimental technique. Well, this is just to show you how it looks. Endoscopically, we are releasing that hexagonal magnet, and this is the anastomosis, how it looks on putting a laparoscope. You can see almost as if you have done a surgical side-to-side anastomosis. And this is through the enteroscope, you can pass through that anastomosis, and this is, you can see the barium picture. Well, there is no wonder that if you were to see the way bariatric endoscopy is progressing, especially for this moderate obesity type of patients who refuse surgery on a number of occasions and for whom lifestyle management is not simple, you can see that this is going to play a major role in the future. A very recent paper, you can see here, 2021, what is the current state of bariatric endoscopy? If you ask me personally, only 2 are clinically applicable: intragastric balloons and tissue apposition devices, or by which we can reduce the contents on the size of the stomach, endoscopic sleeve gastroplasty, by which we can achieve a reasonably good weight loss of anywhere between 15 to 20%. Remaining devices, you see here, remaining techniques can come probably in clinical practice, but they're still under experimental studies. Once they are approved in multi-center prospective studies, I think it will be applicable in day-to-day practice. The incision-less magnetic anastomosis, I think, is still only restricted to certain clinical trials. So I just want on to say that bariatric endoscopy is not only going to play a major role now, but very likely in the future, it can become a part and parcel of a good multidisciplinary obesity center. Thank you for your attention.
Thank you, Dr. Amit, and excellent talk. I've actually thoroughly enjoyed the lecture, and you're absolutely right. It would definitely play a role in the algorithm of treatment of obesity, and it has to be a part of that algorithm. And again, I agree with the fact that probably balloons and ESG is something which creates a lot of excitement, And in particular, in the last few months, it's been the Allurian balloon because of the simplicity of usage, and the patient can just swallow, and that kind of leads to almost a 10 to 12% weight loss, what you just showed, in about 6 months to 1 year's time. We'll probably have a lot of questions, and we'll take all these questions right at the end. So please stay back. Next, I have immense pleasure in welcoming a dear friend and somebody who's doing some fantastic work in therapeutic endoscopy. I watched him do poem in the annual conference in Rajamundry. Excellent work that he's been doing. So endoscopy has also come into play a extremely important role in managing complications in bariatric surgery, particularly if there's a leak, which we know can happen in 1 to 2% patients, bleeds, intraluminal bleeds, stenosis. All these have for the treatment of all these complications, endoscopy has a very definite role, and no better to tell them is Dr. Rakesh Kalapala. He's practicing in the AIG hospital in Hyderabad, which we all know requires absolutely no introduction. So welcome, Dr. Rakesh, for your talk on management of endoscopic management of bariatric surgery complications.
Yeah, thank you for the kind words, Dr. Wadhawan. And at the outset, I thank the prestigious IAGES for giving the opportunity to talk on this platform with Dr. Thangavel and Kanagavel giving me the opportunity. So if you go into the endoscopy for bariatric surgery complications, I think it's like a hand in glove with your surgeon and the endoscopist who have to work in conjunction. Can you see my slides on the screen?
Yes, we can see your slides. Thank you.
So by and large, these are the bariatric surgery procedures which we commonly encounter: the vertical sleeve gastrectomy, gastric band, Roux-en-Y bypass, and mini gastric bypass. So I don't have to go into that. You are a learned audience. So if you see the bariatric surgery, it's very effective, obviously, in obesity and associated comorbidities. But however, you have a certain set of population who have got these fistulas and leaks, which is not very common, but again, not very uncommon. You have RYGB and sleeve leading to these kind of percentages shown on the screen. And you have a minimal mortality rate of 0.1% to 2.6%. But again, not everyone who has got a leak or stenosis or a stricture will lead to mortality, because if you can timely diagnose and then intervene at the earliest, then you will have 100% no morbidity mortality. So we all know about the leak and fistula. Leak is a communication between intra and extraluminal compartments, and fistula is an abnormal communication which happens in the epithelial surfaces. And primarily, all these happen because of inadequate vascularization, tension on the suture line, staple failure, tissue fragility, and so on and so forth. That's again theoretical. So if you see this slide, the complications, what happen in Roux-en-Y bypass and sleeve gastrectomy, gastrojejunal anastomotic stricture, the fistulas, leaks. Again, choledocholithiasis and weight regain are a different topic. I'm not going to touch upon that. Then you have sleeve gastrectomy, which has got the staple line leak and the sleeve stenosis. And of course, bleeds. So these are all the primary things which I'm going to deal with in the next 15 to 20 minutes. Leaks, again, we all know sleeve leaks, majority develop at the staple line below the angle of His, that's the GE junction. And that's because that's an area where you have relative ischemia and high zone pressure. In fact, I would say in my practice, I find more difficult to treat these sleeve gastrectomy leaks rather than the Roux-en-Y bypass leaks. This is again a classification in 2018 published as type 1, type 2, type 3, where you have the leak with no documented collection, leak with an abscess, and leak with a fistula. So this is by and large how we classify the sleeve-related leaks. Again, this is an age-old classification, sleeve consensus. Acute leaks are less than 7 days. Early is 7 to 45 days. Later, that is a little later, is 1.5 months to 3 months, and chronic leaks of more than 3 months. This is very important because you need to understand that the outcome of these leaks will be very positive when you treat in an acute or early phase rather than a chronic phase. RYGB, again, the learned audience, I don't have to tell, the type 1 to type 6, what the leaks have been classified. And the type 1, type 2, and type 3 have got the endoscopic, we can do something endoscopically. And of course, type 4, 5, 6 are primarily led by redo surgery. So how you manage leaks? Suppose you have a patient who's got this leak. Obviously, you have to control the sepsis via drainage, can be percutaneous most often when it's initial days, then antibiotics, nutritional support, very, very important. And most of the patients will have a fantastic improvement in the nutrition if you place an early endoscopy guided nasojejunal tube. PEG is again a little invasive, but I think endoscopic nasojejunal is the best what you can offer in these patients to have a continuous nutritional support in the initial days. And identifying the perpetuating factors is very important. If it is a bypass, then you should look for any GJ stricture which can perpetuate the leak at the angle of his, or a jejunal stricture. And if I have a sleeve gastrectomy, then the downstream stenosis and at the angularis incisura, or at the torsion of the stomach or the foreign body bezoar coming into. So these are all the things which you have to look into once you have noticed a leak earlier. So it's again a multifaceted approach. It's not a single man show. You have to have your bariatric surgeon, bariatric endoscopist, and interventional radiologist, in a team approach where you have to discuss time and again, day by day or kind of hour by hour about the prognosis of the patient. I just start with a case scenario. So this is one who had a post-sleep day 5 patient suddenly developed tachycardia, spiked temperature of around 101, 102 Fahrenheit. And the best I feel in this scenario is to do a CT scan where you can see 60 to 80% of the times you can, pick up something on CT abdomen. So when the CT abdomen found a drain collection, immediately what has been done is we pulled our interventional radiology team, and then they have put a percutaneous catheter to drain the source of sepsis. So if you see the endoscopic treatment in these scenarios, as I told you, the early you pick up, the best of the results. If you have picked up your leak and then you have done before 3 weeks some endoscopic treatment, then the success rate is 90 to 100%. But as the time passes, if it is more than 3 weeks, I'm sorry on that, it's 70%. So early treatment is key. Again, if you can address the patient at the leaks level, then you have a clinical success of 100%. But once the fistula forms, that is, as you delay the diagnosis and treatment, then the percentage of clinical success will come drastically low. So again, I'll just skip this slide. So what we primarily do in endoscopic techniques is 3: closure, covering, and draining. I'll tell you what are these things. So closure is you have a leak, you close it. Cover is you cover it, and drain is you drain that leak outside. But meaning by thereby, if you have closure techniques, as you see on the screen, the tissue salients, which are basically for low output leaks, and of course the disadvantage of this is a little costly and not commonly available. You need multiple sessions. But again, the cap mounted clips have taken a paradigm shift in the management of these patients, the Ovesco clip and padlock, where even up to 2 to 3 centimeters leaks can be easily dealt with. And you need the external drainage, and you have variable efficacy. Suturing, again, Dr. Amit will agree with me, being a bariatric endoscopist, suturing is not that easy, and you need a proficiency and efficiency to master in the sutures. So conventional clips, again, in leaks, I personally feel there is no role on that. I think Dr. Amit also will agree with me. And the covering techniques are again 2 types: stents and cardiac septal defect occluders. Stents are again the commonly used. Efficacy is 70%. And the advantage of this is once you put a covered stent and seal the leak, you can have an early enteral nutrition, the oral intake, which will not deplete the nutrition. And of course, again, it's not as rosy as it appears. You have 30% migration, and you need to probably have some external drainage. And once you remove the stent after 2 to 3 weeks, you might have a surprise of tissue ingrowth and so on and so forth. And the other one is a cardiac septal defect occluder, that is ASD closure device, which we quite often do in our unit also. In fact, for lack of time, I didn't want to show, but otherwise there's good videos on that. So this is again one thing which has got a significant role, especially when you have a tracheoesophageal fistula, where you can have a biflange kind of stent, which you put it bronchoscopically and endoscopically with your pulmonologist, cardiologist colleagues. It's a teamwork where you can occlude the leaks with this cardiac septal defect. Draining techniques, this again is a paradigm shift in the management of bariatric surgery complications. So you have primarily the septotomy, endoscopic vacuum therapy, and double pigtail stents. Septotomy is like, when you have a septum, you do a septotomy, and then you release the high zone pressures. Again, it's not quite often, but you do see in some cases. Endoscopic vacuum therapy, again, is a very commonly used technique. It has got a very good efficacy of more than 90% improvement in or curing the leaks. I'll just come to the next 1-2 slides. Of course, the patient will have a discomfort because you have a nasogastric or a the tube from the NCT or nasocystic tube, which will have some discomfort on that. And you obviously need a hospital stay for that. Double pigtail stents are again a big major change in these leaks patients, because the stent, you put it in as a pigtail, one pigtail in the cavity, one pigtail in the stomach, which will create a high pressure to low pressure zone. And that leads to very good improvement with the collapse of the cavity. I'll just come to that again. So as I told you, the self-expandable metallic stents, as its early leaks or acute leaks, it's very good. And you have a complete covered stents. You have different companies coming into. In India, as of now, we commonly use the Tevung one, the mega stent. And I'll just show you the video how it is done. So this is a patient recently, last 1-2 weeks before. So he was 130 kgs, and then he had a post lap sleeve gastrectomy, unfortunately leak at the anastomotic side, as you see the G junction leak. So what we have done is, you see initially I've put a fluoroscopic guided contrast so that I can know exactly where I can leave the stent. So this is the fully covered mega stent from Tevung company, which is done. So again, it's not as rosy as you see. You can have migration issues in this 30 to 40%. Then you can also have severe crampy pain in the chest. Of course, we have to maintain them with analgesics and antispasmodics. So the new invention or the new advantage in the endoscopy field is, suppose if you want to prevent the migration of the stent, then you have this over the scope clips. It's called ovoscope clip. So the advantage of this clip is you can hold the stent and then prevent the migration. And as you see this in the video, this is a very simple technique where you hardly have 10 minutes or 5 minutes kind of, where you can just put that clip so that the stent won't migrate down. So this is one clip which we commonly use quite often in many of our luminal endoscopy stents, where the stent is fully covered and the chance of migration is low. And again, the meta-analysis on the self-expandable metallic stents, as you know, the success rate is around 80 to 90%, but again, the chance of migration is more, and you need some suture some fixation, which used to be done earlier by suture, but now with the ovoscope clip, I think things have become pretty better. And coming to endoscopic vacuum therapy, which again is commonly used, you have two types in that, the intracavitary and intraluminal. Intracavitary is you put the sponge into the cavity, and then with a nasogastric tube, you drain it continuously with the antigrade pressure. Intraluminal is you don't get into the cavity, but you put it at the origin of the leak, and then that sponge will assist in sucking the fluid, whatever is accumulated there. So these are two things, and only disadvantage is it's a little challenging to place the vacuum therapy, and also you need multiple exchanges and you need hospitalization. So as I told you, the double pigtail stents paradigm shift in this, you see on the screen, the low pressure and high pressure zone. From the high pressure zone, the fluid comes down to the low pressure zone. And these are primarily of paramount importance, and success rate is good when you have a post bypass leaks rather than a post sleeve gastrectomy leaks, because LSG has got high pressure, and in that the success rate is 80% vis-a-vis compared to 97% in bypass leaks. Again, coming to the chronic leaks, stents are of not very big efficacy because the migration rate is high, and they are not as effective as you see in the acute leaks. So that's the reason why pick up early, act early, and then you get the best results. So now, as I told you in the last couple of slides, you also should know what is the best endoscopic approach and when you should not do. That's more important, right? So the tissue sealants not indicated for acute and early leaks with perigastric collection because there is no work. Cap mounted, the ovoscope clips, again, if the orifice is more than 2 to 2.5 centimeters, it might not work. Suturing, you need expertise. Cardiac septal defect occluder, not indicated in collections with acute leaks. Septotomy, if you have no septum, there is no role. And double pigtail stents, again, if you have a large collection, it does good. If you have a small collection, you obviously cannot push in the stent. So in one breath, what you should do and what you should not do is what I thought I'll tell you. This, I think, again, is a little elaborative slide. This is available anywhere in the textbooks and articles for the students if they have logged in. So this is the leak, how you manage. I'll skip this. Then the second is the stenosis versus stricture. So primarily in this, the treatment is balloon dilatation and self-expandable metallic stent. And off late, what we're using is the LAMPS, that is lumen opposing stents. So the balloon dilatation is very commonly done once you have this stricture or stenosis post, especially the anastomotic sites. So we use pneumatic balloons. You have a couple of different types, but the most commonly used is a CRE, that is controlled radial expansion balloon. Of course, you have failure rates in this because if you have a long stenotic segment or a twisted sleeve, they might not work better. And mechanical stenosis often in the body happens and narrow tubulization, as I told you, the failures which happen sometimes. This is one, I think it's not a very interesting one. It is interesting for the doctor, but not for the patient. This is a young lady, IT professional in Hyderabad, who had sleeve gastrectomy a couple of years before. I'll tell you a story in 30 seconds. Then she had a G junction leak. She went to an endoscopist who has put, unfortunately, an uncovered stent. And with the uncovered stent, there was a tissue ingrowth. She didn't really have a relief. Then she came to AAG. Then we tried to pull out the uncovered stent. By that time, the tissue ingrowth happened. And then our surgical team has to intervene. And then they pulled out the stent. They did a esophagocolonic anastomosis because the whole residual stomach is completely stuffed off. And she had 1.5 years of STROMI course. She being obese went into malnourishment, unfortunately. And after that, she was settled kind of, went to UK. And last month, she came back with a minor leak at that esophagocolonic stricture or the anastomosis. It's not stricture, anastomotic site. So as you see it on the screen. So this is so unfortunate. But after that, she had it from past 6-8 months. And then slowly the leak has contained itself. But she started having dysphagia because of the esophagocolonic anastomotic stricture. And as you see here, as I told you, we did a CRE balloon dilatation up to 18 mm. And after this, she's doing fine. So this is one of the rare complications which happen with surgical bariatric surgery. And this is how you treat simply with very easy with endoscopy. Again, refractory gastrojejunal anastomotic stenosis, which you all know. So this is where the lumen opposing stent is of much use, and we quite often do it, especially when our surgical colleagues refer for these refractory strictures. So if you have the refractory strictures, you also have other treatment options like steroid injection, incision therapy, and stents. But by and large, you need to have a dilatation. So sleeve stenosis, less than 2 to 3 weeks, you do conservative management. And if you have more than 2 to 3 weeks, because stenosis, unlike leaks, you need to buy some time, because if you put in a self-expand metallic stent or do some dilatation, that leads to, perforation. So you have to buy some time for stenosis to treat, unlike leaks where you have to intervene early. And as I told you, factors related to failure, long stenotic segment, and twisted sleeve. Coming to my last part is the bleeds, which you quite often encounter. And there are a lot of tools in the armamentarium of therapeutic endoscopy, which are the through the scope clips, over the scope clips, hemospray, padlocks, and endosuturing. So as you see here, the conventional clips are the hemo clips, which are the thin ones, and the Ovesco clips are the broader ones. So if you see here, tips for success of any bleed when it happens post surgery is you should not clip on the side where it is bleeding, but you have to first clip on either sides and then clip on the side it is bleeding. As you can see here, this is a post anastomotic side bleed, the gastric ulcer. It's a spurter. So you see what I'm going to do is, I'm not going to exactly clip on the side where it is spurting, but on the either sides, you do clip, and then after doing the clip on either sides, you put it on the center. So you need multiple clips, but you need to block the vessel on either sides where it is spurting, and then exactly on the spurter side. You see now it's completely stopped. Again, this I told you, it's a paradigm shift in the field of endoscopy. You see a torrential bleeder who stepped in. You can see it's like a fountain bleeding. So this clip has got a suction apparatus where you can hold the mucosa on either sides of the bleed spurt and then suck it inside and then apply the clip. As you see on the screen, the clip is applied, there's complete stop of bleeding. So this is one thing which, as a bariatric surgeon or also bariatric endoscopists, should keep it in your hand once you have these complications. Again, this is again a last week case from a bariatric surgeon. So this is, I think, probably the very fancy bariatric surgery now being done, the one OAGB. So what happened is, after 4th day of post-op, the lady had a jejunal anastomotic side bleed. And then my surgeon came to me. So we did an endoscopy. And mind you, at this, I'll tell you one practical thing which happens when you have a multi-speciality is you should always have your surgeon when you're doing any endoscopy for a bariatric surgery complication, because he is the one who knows about the anatomy, what he has done. Unless and until he is there, you are blinded. Trust me. So you have to have him with you. And you also, the endoscopist, should understand the anatomy of what happens after sleeve gastrectomy or after gastric bypass. You see here, there is a spurter. So then I took a hemo clip. It's from the, it's evolution clip. And I put a first clip on that. And you need a water jet. They're all practical tips. You need a water jet because you just keep a clip and then come out, you don't know what's happening. You need to flush. And the second clip is again put adjacent to that. And you can see in the next 10 seconds, the complete stoppage of the bleed. See, it is completely stopped. And the patient went back happily. So just to conclude, in this bariatric endoscopy for surgical bariatric surgery complications, post-surgical leaks are the most feared complication for a surgeon. And you all are the learned audience, you know better than me. So increasing incidence of sleeve gastrectomy nowadays is obviously increasing prevalence of sleeve leaks, and important to consider timings in surgery, leak size, and distal obstruction. Endoscopic armamentarium is growing and growing, and many new and evolving devices and techniques have come, and they are also coming in the pipeline. So most post-bariatric leaks can manage effectively through an endoscopic approach, especially when you pick up early and act early. As I told you, I am telling you again. Close collaboration between bariatric surgeon, interventional radiologist, and interventional endoscopy. It's a teamwork. Trust me, if you don't have a teamwork, you can never succeed in this program. And internal drainage, as I told you, is a paradigm shift in these surgical leaks management. And the toolbox for managing these complications is expanding. And I am sure in the next coming decade, you're going to have so many things. And it's always, in a lighter note, you should be having a close relation of a bariatric surgeon and bariatric endoscopist. Probably every week you should go, either of you have to go for a drink and then manage the things. And you should work in conjunction. Especially Dr. Amit will agree with me, the bariatric endoscopy is going to be the next, in the next decade or two, it's going to be the main thing. And as bariatric surgeons and endoscopists, they should balance the things and give the best to these people who are obese. With this, I'll stop, and then I think I haven't overshot the time.
Thank you, Dr. Rakesh. Now I request Dr. Amit to first place his comments before I move on to the questions. Dr. Amit, please.
Yeah, comments about what Dr. Kanagavil. I was very impressed with Dr. Rakesh's lecture because, post-bariatric surgery complications are not easy to handle. Because sometimes, it looks so easy, you can just place a stent or apply a clip or do this and do that. But these patients are sick, and anything you do, the leak does not stop so easily. They develop infective complications, prolonged hospital ICU stay. So it is a little difficult problem. We do not have very clear-cut answers as far as this post-bariatric surgery complications goes. And as far as the endoscopic treatment for obesity, I already told you that presently we are only having two techniques, that is balloons as well as the sleeve gastroplasty. But these are reasonably established techniques and they can be very routinely clinically applied to patients who have a mild to moderate obesity. Any other questions are there?
Sir, I think I have two questions on the chat box. One is there a risk of complications on endoscopic weight loss surgery by Dr. Kabali Murthy? Can Dr. Amit take this question, sir?
So, are there any complications?
I think he is meaning endoscopic gastroplasty. What are the potential complications, and then how often the complications happen? This has been the question by Dr. Kabali.
Yeah, one of the potential complications is bleeding. There can be intragastric bleed because you're taking sutures and multiple bites in full thickness in the stomach. And especially if you go near the fundus, the bleeding can happen. Sometimes there can be some perigastric leaks, perigastric collection. Rarely, if you start suturing the fundus, you may even damage the spleen. No major adverse events have been noted till now, like perforations. And none of these patients, there have been shown any mortality because of any adverse events because of endoscopic sleeve gastroplasty. Some patients may get readmitted to the hospital, even if you have discharged with severe epigastric pain, cramping, vomiting. And very rarely, you may have to go in and cut the sutures and open up the whole suturing. So otherwise, there are no major complications. Balloon, there are virtually no complications. Yeah.
Thank you very much, sir.
Thank you.
I also like to ask one question. With so much of vast experience on endoscopic weight loss, is there a role for endoscopy in weight regain after a bariatric operation?
Yes, very much. There are two situations. One is a lap sleeve gastrectomy where the stomach has dilated. These are the ideal candidates where we can go in endoscopically and again reduce the size of that stomach without surgery. Second is patient who has undergone a Roux-en-Y gastric bypass where the anastomosis has dilated or widened. There also we can go in endoscopically, we can do argon plasma coagulation on the anastomosis and reduce again that anastomosis. So we can shorten it again, we can narrow it again. So these are the two main places where post-bariatric surgery weight regain, this is useful. Endoscopy becomes useful.
There is one question from the doctor, which goes on to say, I think he wants to know if this endoscopic bariatric operations like endoscopic gastroplasty needs less surveillance, like post-operative surveillance, because many bariatric procedures now need very close surveillance for almost 2-3 years and on a lifetime basis. He says if this will be a replacement procedure for a full bariatric operation in rural setup where they have resource challenges. What is your thought about this, sir?
No. This also requires proper surveillance because obesity is not just a simple disease. Obesity is a disease of the mind. And if you do not have a very close surveillance, if you're not in contact with the patient, a nutritionist, counselor, all the time motivating the patient, this patient is not going to follow a proper diet. In spite of any restrictive procedure we do, the patient has to be in continuous contact and motivated. Only then we can achieve a reasonably long-term and durable weight loss. Otherwise, this is not going to happen. So just because you have done endoscopic procedure does not mean that it doesn't need close surveillance. It requires equal surveillance like surgery.
Thank you very much, sir. Now I'd like to ask one question to Dr. Rakesh. Dr. Rakesh, I'm sure AAG is involved in many experimental procedures. Very clearly, Dr. Amit has excluded all the experimental procedure and he has right now showed only the very validated procedure which has been universally accepted. Can you briefly tell us what are the experimental things maybe still yet to be fully approved, which are upcoming and has a good potential as an endotherapy for weight loss? Dr. Rakesh, please. Sir, please unmute yourself, sir.
One thing what I want to emphasize following Dr. Amit's comments is, if so is going to endorse bariatric endoscopy as standard of care with some consensus guidelines being published, going to be published in the near future. So once that comes, then bariatric endoscopy is going to have a big leap, especially as I told you, you have to work in conjunction with the bariatric surgeon, probably up to 35 BMI. Those people are going to have the best results with bariatric endoscopy. And coming to the question what you asked about the new experiments. So as Dr. Amit told, duodenal sleeve is one which we are looking forward, which will be a major game changer, especially in people in India where we have this diabesity, like diabetes and obesity, which we look upon. And that's one device which we are working close with some folks in Minneapolis, where that is going to be a device which an average endoscopist can perform even in a 2 and 3 tier cities. It hardly takes 15 to 20 minutes. So that's one thing which we are closely working from our heart, and which I feel is going to be a big game changer in patients, especially with diabetes and indirectly with obesity. Number 2 is we are also working with a group from University of Michigan, where we are developing a device called Full Sense, which will create early satiety at the gastric level. That's again in experimental level. The third is, as Dr. Amit showed, the duodenal mucosal resurfacing, which they use the hot water technology, which is a little crude. Now the next level is we are working on electroporation, which is a kind of ablation of this duodenal mucosa, which will change the insulin sensitivity pattern with alteration of GLP-1 analogs. So that is one thing which also is being looked forward in the near future. I am telling you these things because electroporation or DMR is a reproducible technique. You can do it every 6 months or 1 year. There's no harm in doing it, as Dr. Amit should also agree with me. But again, the devices, the duodenojejunal bypass liners are easy to deploy, and those also we are looking forward. So I think these are 3-4 things which are there in the pipeline, and I am sure in the next 1 to 2 years we'll come up with strong positive results on these devices.
Thank you, sir. Now I have one difficult question, I would say. Somebody has asked, sir, for transplant patients, hepatic transplants and organ transplants, obesity is one major factor which makes the transplant surgery less successful. What is your take on it? You would like to know if endotherapy or endoscopic weight loss is an option prior to transplant as an interim measure. And then if yes, do you have experience? I think both of you can answer to this question, which both of you are having good experience in this. Maybe this is not a very common scenario, but he says the transplant surgeon would like to have a weight loss for considering him for transplant. Please share your thoughts, sir.
So it's a very common scenario. In fact, our transplant surgeons, they refer both the recipient and donor for weight loss, because the recipient, again, weight loss is important for the post-op positive outcome. And in those patients, I feel the best is putting an intragastric balloon and then having a weight reduction of 10 to 12%, both in the recipient as well as the donor who has got a fatty liver. It's a very common scenario, and we quite often practice this in our routine daily, where our liver transplant surgeons refer a lot of these patients into this. Coming to endoscopic sleeve gastroplasty, obviously in a recipient, it is not advisable because they have this portal hypertension. But in a donor, it's again one thing which we can consider if they are very obese, like, between 30 to 35 BMI.
What is your take, Professor Amit?
In our setup, we usually place balloons for transplant patients, both recipient as well as donor. And that is a very relatively simple thing to do, and that works sufficiently well for transplant patients.
Yeah.
We usually don't try to dabble in gastroplasty because donor is too normal to undergo a gastroplasty. They don't want to take any chances unnecessary. And recipient, sometimes the stomach is very vascular. It can bleed very easily.
Yes.
So balloon is the right approach.
Yeah.
the point is well taken, sir. Before we close, there is one other question in the platform. They would like to know what is the status of pacemaker or implantable devices for controlling appetite. Are we working on it, or what is the state?
I'm not aware of any pacemaker to control appetite, because we have got pacemakers to empty the stomach. That is a possibility, but we don't have any
For
pacemaker.
gastroparesis correction.
Yeah, we don't have a pacemaker which will reverse the stomach peristalsis or cause gastroparesis. No.
Yes.
Do you have any thoughts, Dr. Rakesh?
No, I agree with Dr. Amit. So there's nothing for that till now. So it's actually a good idea what they have given. Let's work on it.
Thank you very much, sir. I think on behalf of the president and the conveners, I thank both the faculty for sharing your wisdom. I'm sure the delegates and the participants would have benefited maximally with all your vast wisdom and experience. Can I have the honor of inviting the Secretary of the IAGES to propose the closing comments and vote of thanks. Dr. Maydeo, please. Dr. Maydeo, sir? I think he has some challenges. So, on behalf of the Secretary, I thank all the. I think Maydeo is back.
Good evening. So, thank you very much, Dr. Amit and Dr. Rakesh. So, we had wonderful discussion on the both where to use this technique. Obesity, we know that it's an emerging problem, and we have to face it. As you have rightly said, that it's a disease of mind, and a metabolic disease involving many systems of our body. And endoscopy has many answers to offer. Thanks, Rakesh, for putting forward many complications. We know complications are part of it, and many a times the complications by surgeons also are being tackled by endoscopy. So both of you have put forward your presentation very nicely, and it has been very helpful to all of us. So thank you very much again for sparing your valuable time. Thanks our President and Randeep Wadhawan for being here. Thank Dr. Kanagvel, who is the convener of this show. Thank Team DocPlus for arranging this prime time for IAGES. Thank you very much. Good night to all of you.
Good night. Bye. Bye.
Thank you, faculty. Thank you.
Bye.
Good night.
Thank you, one and all. Good night, everyone. Doc Plexus, we are out. Thank you very much. Nitin.